and influenza of coronavirus in UNC. Him is that when he responded to a request from the Financial Times, I'm going to go ahead and say it because screw them, they need to be on the record for this. When he responded to an interview request for the Financial Times, he actually said that what he was doing was in fact helping civilization. And thousands of people were going to be saved because of his vaccine work that he was going to enable. Conveniently leaving out the fact that in 2016, he published a paper saying, and I quote, "SARS coronavirus is poised for human emergence."
Meaning?
Meaning that he had built the bomb.
Not meaning that it's out there and we might...
No. Because if you read what he actually wrote in the paper, and a lot of people who do nothing but read the headlines go, oh, well, he's just warning us that this might be coming.
So it sounds like...
Yeah, it'd be nice if it wasn't a synthetic chimeric alteration of the thing, which is not natural, right? Poised for human emergence hardly is, we've built it in a lab. And we're supposed to believe a story that this came out of a bat cave, even though, as of this date, which is the end of July 2021, we haven't found a single bat that even has a remote resemblance of this particular pathogen. But we're still supposed to believe it came out of a bat cave. We just haven't yet found the bat cave, but we have found, allegedly, thousands of cases all over the world where it exists in people, but we can't find it in a bat cave, even though we know the bat cave, where it came from in 2013, when it was natural. When it was natural, we could find it. We can't seem to find this one.
So just as a quick interjection, is it conclusive in your mind this is a man-made, not a natural occurring
Absolutely.
virus? Okay. So just
That's not even a question.
100%, not even a question.
It's not even a question because the published evidence is all in patent records and is all in scientific proceedings. There is no question at all that this did not come from a bat and a pangolin walking into a Chinese bar and getting it on one night.
That completes part one of my two-part interview with Dr. David Martin. As you can see, we're looking at somebody with pretty extraordinary intelligence, and part two just gets better, so make sure you tune in for that one. Thanks for being here. Coming up next is part two of my two-part interview with Dr. James Lyons Weiler. If you saw part one, you realize this man has great expertise and experience in the realm of molecular biology, so he can interpret what we need to understand about COVID and communicate it in a very passionate and powerful way. I always enjoy my conversations with him. He delivers on a high level. Let's jump in on part two of this interview. When we spoke way back when, you were pretty critical of the PCR test, and for good reason. And I would say probably psycho-emotionally tortured by the concept of this test and its inability to do what people wanted it or proclaimed it to do, and the fact that it was being run at scale and that policy decisions were being made from bad data. And you scale bad data, you scale bad decisions. With that. And now, here we are, because everybody else, not everybody else, a lot of people are lauding the PCR test and it being a standard for whether people can travel and go here or there, or whether they have are infected or not infected, et cetera. Now we see that, and this is a test, again, emergency use authorized, not vetted fully for what they're saying as a diagnostic test for COVID infection. Now they're taking it off the market at the end of this year. So how does this thing, which basically drove our machine, it was like the prime motor of the machine, suddenly they're taking it off the market. So what's going on?
So through the lenses that I look at this through, here's what happened. When the virus made it to the Princess cruise ship, right, they had at their disposal a test that was created by Germany, the Drosten test. They could have adopted that test. It was already validated in the lab to work as well as that test works. And when I was reading about the Drosten Laboratory, I'm like, okay, this is great. They took a bunch of sputum samples from patients who didn't have COVID. They were historical samples. There was no COVID in 19, at least we thought in Europe at the time, to determine what's the probability that this test is going to give a false positive. Okay, very important, right? And then they took samples where they spiked in the sequence of the virus that they actually created. And that, I've got to watch my terminology. They reproduced subsequence of the virus from the published sequence from China, and they spiked those sequences into samples. And then they validated that, yes, this PCR kit will amplify those nucleotide sequences, those particular sequences. In other words, the Drosten test came out of that lab with sensitivity and specificity measures. We knew what the probability is that it would detect the virus if it was present. We also knew the probability it would not detect the virus when it was not present. CDC took it upon themselves to reject that test after 142 other countries had adopted it, and they wanted to develop their own. They developed their own and they shipped out a flawed test. The Princess cruise ship, this goes all the way back to the Princess cruise ship days, right at the very beginning. Those people were let off the ship after being tested. Everybody that was negative could leave. Was not even a field tested, laboratory tested kit. It was flawed. It didn't work. Many of those people that left the cruise line ship developed COVID and spread it, and that's why it took off like wildfire in the United States after that, right? So what I believe that the CDC did was they said, well, what we can do is we can use the PCR test, but we'll bias it to the point where we won't miss any cases. We have to catch all the cases. Because if we don't catch all the cases, this thing's going to get away from us. So we're going to bias it so that what's called the cycle threshold, the number of cycles that the machine has to run before you reach a certain level of amount of replicated material, we're going to run it all the way up to 35, maybe 40, okay? And then we're going to call you positive if that happens, knowing that there's going to be false positives. But then they did something that was constructivist in philosophy.
I'm just going to say, false positive means that you took the test, you really don't have COVID, but it comes out positive anyway. Is there any numbers that have been published or represented of what percentage of false positives we're getting from the PCR test?
Yeah, the numbers I've seen, and I've cited these, are 11% from Australia all the way up to 90%. And it's waned over time. So then what happened was they said, if you die with COVID, you died from it. We're going to equate the presence of the virus with the disease. So the PCR positive result means you have COVID. So we're not going to worry about symptomology or anything like that. And they did that so that they could then justify why all these people are walking around with positive PCR tests, but they don't have any symptoms. Okay. And then their spin machine decided, well, look, we've got all these asymptomatic patients. We're going to say maybe asymptomatic transmission is occurring. We're going to scare the heck out of people. Okay. And this is all through my lens again. Okay. Now, the reality is that they should have looked at the false positive rate. I wrote to Peter Marks and at the FDA. He's the director of the FDA. And I said, you have to put the demand on these companies to show the specificity. We need to know the false positive rates. Otherwise, you're going to create an economic disaster. You're going to have people that are quarantining all over the place. They're going to have teachers that can't show up to teach. You have people in critical areas of the workforce that can't show up to work. Because if you do this indiscriminate testing, you end up with hundreds of thousands, if not millions, of false positives relative to the few true positives that you have. So this was their paradigm. And this is a constructivist philosophy that what we say is true, it's our strategy, it's going to manipulate the public's perception, and then therefore we're going to control what's happening. But they can't control it. They're delusional that way. They think that they can control that, okay, we're going to do this now, but what about 9 months later when there's so much selective pressure against the spike protein that the tests start failing? There's so much selective pressure against the actual primer sites that bind to the genome of the virus if it's present, that the tests start failing. And so you start getting a huge amount of false negatives in addition to the huge amount of false positives, and the testing becomes basically useless.
Well, so and it's just so I could say, so two things. Number one, selective pressure, meaning Evolutionary pressure?
Evolutionary pressure. Well, every time somebody tests positive, if they actually had it, they were quarantined. So that particular virus won't replicate. The ones that the test works for won't replicate. Sitting right next to them, right on the way home, is somebody that got COVID from them, but it mutated in the primer site, so that test won't work. The PCR tests are made of nucleic acid sequences that have to match the primer site. And there's data that this is not idle speculation. Like 8.5% of all the known new variants, those variants map to known primer sites from testing kits. And the genome is 39,000 bases long. So we're looking, and these primer sites are only 21 bases. So, up to 21 bases. So we're looking at an intense amount of selection. Of course, I mean, it's bound to happen.
So we're looking at now false negatives, which is the opposite of false positive. False negative says you actually are infected and it doesn't pick it up. But what's interesting is what you're saying. You say, hey, we took all the people who tested positive, we took them out, but there's a bunch of people who were tested negative, which means that somehow it evades detection, and that's what's getting spread. And therefore, over time, it makes the test obsolete.
And it makes a great deal of sense that you have an evolutionary biologist looking at this problem, right? So when I looked at the problem, I wrote to the lead virologist in the UK, Andrew Rambo. You might recognize that name because he was on the list of the dirty dozen that were talking with Anthony Fauci in that secret phone call. And Anthony Rambo decided to beat his chest at me over it, is the best way I can describe it. What makes you think that with all the hundreds of scientists that are working on this problem that we didn't already think about that? Well, perhaps, Andrew, it's because none of you said it when you said it was a good thing that the primer dropped out, because now you can tell the difference between the UK variant and the original. So when the PCR test fails, it becomes basically useless. However, it's not entirely useless because the PCR tests are designed to work if 2 out of 3 of the primer sets light up. So imagine you've got a board and it's got 3 lights on it. If 2 of those, any 2 of those 3 or all 3 light up, we're going to call you infected. So if your bulb is out in one of those lights, you just cut down your possibility of a positive if it's present by 50%. So your sensitivity is shut down by 50%. But it still works for some people, right? So what the CDC has decided to do is, well, we can't really very, very well continue this PCR testing the way we've been going with these high false positive rates, okay, because we're vaccinating people. And it's going to make the false positive rate is going to make it look like the vaccine's not working. We're going to have a lot of breakthrough cases. We can't have that. So they dropped the cycle threshold to a reasonable cycle threshold of 28 plus hospitalization or death for the vaccinated. For the unvaccinated, they're still using cycle thresholds of 30, 40, whatever the kit.
So they're basically using different testing parameters for vaccinated versus unvaccinated people. Is there any explanation other than the fact they're trying to skew the data?
When I called them out on it, right? It was USA Today or PolitiFact or one of these organizations criticized IPAC, my organization, for calling them out on this. And they published an apologia. They said they got a doctor from somewhere that said, well, those are the most important cases. The ones that are sick, those are the most important cases. So we're only going to report the most important cases. So they're still collecting. So it's really interesting because there's actually a smoking gun of a cover-up in this. Because if you go to the original URL for the guidance that says, we don't even want to hear about it unless it's 28 or less, and the person's hospitalized or dead. If you go there, now there's a PDF that loads up and says this website's been updated and redirects you to something that's unrelated to this. So you go down this literal rabbit hole of nothing. It's a misdirect. But the Wayback Machine, the archive still has it, and I still have the original document. Now what the CDC does is they collect all the data from all the breakthrough cases, all the vaccinated cases, but they capture the CT threshold, right? So we really don't know unless they publish the CT threshold distribution of all the vaccinated and the distribution of all the unvaccinated in any report, whether or not their report's completely biased. The problem is if they're not using the same denominator, you can't compare rates, right? So that's a huge problem. And today I've just published an open letter to the CDC about this because they looked at the rate of reinfection in Kentucky, right, in the vaccinated versus the unvaccinated, but they didn't define anything about the CT thresholds. So if they're using different CT thresholds per their own guidance, it's worse than that, Patrick. The CDC actually doesn't consider you vaccinated unless you've survived to day 14 after your second dose. You're still unvaccinated. So anybody in those studies and reporting the data that dies or gets an infection or a reinfection or has to be hospitalized for anything respiratory because their immune system's harmed by the vaccine or something, that counts towards the unvaccinated.
Wow.
Day 14, and we know in the animal studies that it happened immediately. All the antibody dependent enhancement, the disease enhancement, that happened immediately. They're biasing their data, and then further on later on, after 90 days after your second dose, you're magically unvaccinated again. They have this narrow window of between day 14 and day 90 where you're truly vaccinated.
How can you say that after 90 days you're not vaccinated anymore? I mean, is that really the criteria for inclusion?
Absolutely, 100%. It's verified. It's on the CDC website. It's 100% correct. And go to jameslyonsweiler.com and you can look at my open letter to the CDC today. So the fact that they misdirect, and we have to go to the Wayback Machine to actually get their original guidance, that's a cover up over what they're doing, because they got nailed. We nailed them for it. And then they said, well, these cases, the vaccinated, these breakthrough cases are the important ones because they're sick or they're dead. These are the ones we really want to focus on. But they're not doing the same thing for the unvaccinated. So it's utterly biased. You've got the PCR test that's failing. You got the PCR threshold that's different between vaccinated and unvaccinated. And then what do you have? You have a designation of unvaccinated up to day 14. And I wrote in my letter to Dr. Campbell at the CDC, if you guys are not counting anyone who's gotten the vaccine until 14 days after the second dose, shouldn't they wait 14 days before they get their vaccine card?
Right, which they get immediately. But these are bombshells. I mean, I don't know how else to explain this except for willful intent to mislead.
Not a mistake. This is not done by mistake. This is all, again, go back to the Princess cruise ship and understand that they shipped out a flawed test. They are responsible for the spread of COVID in the United States by shipping out that flawed test. They couldn't do contact tracing. There has been no meaningful contact tracing in the United States whatsoever. There's been no meaningful capture, nothing. 100% nothing, zero. So they basically, public health didn't do their job, right? They couldn't do their job. It got away from them. So what are they going to do? They're going to bias it to the point where they're going to say it's an emergency. We're going to justify this because it's going to get out of hand if we don't. So we're going to bias the test. Now they're biasing the test downward because we don't want people to stop vaccinating. It's just layered lie after lie after lie of this constructivist paradigm. And it's about time in the United States of America that we have a science-based paradigm running public health. It's about time in the United States that we have evidence-based medicine, not this constructivist baloney where they make something up and they say it because they're the CDC, it becomes true. They, this is a case, if it's PCR positive, was not medical. That was policy. That was 100% policies so that they could try to get this thing under control. Out of the best of intentions, perhaps. Either way, they're lying to the public. We know Fauci's admitted lying to the public over masking. So we know that they do it. And it's harmful. It's harmful because there are smarter people than them out here in the public, in academia, who can help. There are people that are far smarter than the people running CDC. And I'm not patting myself on the back by saying I'm one of them, but I am saying that I know over 99% of the physicians that I worked with at the University of Pittsburgh Medical Center, the University of Pittsburgh Medical School, and across the campus of the University of Pittsburgh were highly ethical people. They were super intelligent, and I admire my colleagues. They would never tolerate or brook this baloney. This is damaging. It's one thing to try to be kind to a patient who, we don't know when you're going to die. When 99.999% of people that you're talking to have terminal cancer die within the next day for this type. We just don't know, but we're going to make you comfortable, get as much time with your family as you can. That's a kindness, because it's horrifying to know that this is your last day on earth, whether whether it's cancer or whether it's you're being put to death for crime or something like that, capital punishment. It's horrifying, and so what they're doing is patronizing. What they're doing is destroying America. What they're doing is leaving us wide open to false biological attacks that activate this entire program of lockdowns and shutdowns and quarantines by some terrorist agency or by some other country that wants to harm and harm us. And we need transparency, we need forthrightness, and we need truthfulness from the CDC, from the NIAID. But they're in my view, they've gone too far. They're non-viable as leaders to get us out of this. We cannot vaccinate our way out of this. We cannot do anything, and none of their recommendations are going to get us out of this. What we need to do is listen to guys like Pierre Corey, and we need to listen to Peter McAuliffe, and I dare say throw my hat in that ring too, where we can do science that's objective, and the public will respond very well to the following. My message is going to be very difficult for you to accept. My message is going to be, in fact, quite painful. But there's not enough masks to go around, and we have to prioritize it for the healthcare workers. So I've asked the President of the United States and all the governors to issue and work with the legislature to write new laws that you cannot hide masks. You can't hoard masks. And, if you're consuming masks a lot because you like to go shopping and that's something you like to do, why don't you just stay at home and limit yourself to one mask a week?
Are the masks even effective?
Yes, N95s are effective. Yes, they are. And those were the ones that were in short supply. Okay? So an N95 mask will be extremely effective at blocking this. It's fine, right? Well, but this is the message. This is the approach that they should have taken, but they're incapable of being forthright. They have proven themselves to be pathological liars. Mm-hmm. It's in their DNA, it's in their blood. It's the only way that they know how to do it. And it must be horribly stressful for these people to work in these jobs, knowing that what they're doing is layering lie upon lie upon lie in a stack of cards that eventually is going to come tumbling down.
Is there a growing chorus, though, of scientists like yourself? Because I look at different realms. You've got the clinical realm. You got people who are just literally working on the front lines and clinically interacting with the patients. And there's a whole thing there. And we could talk about early intervention, ivermectin, hydroxychloroquine, zinc, IV vitamin C, et cetera. And then you've got the scientists who are looking at the predicament on a wider scale. Not rather than saying I'm dealing with a patient who comes in and I have there's a whole area of study there that needs to take place. But then there's now let's look at the the virology and the vaccinology and the evolutionary biological implications of what's going on right now, which is what you're speaking to, saying, hey guys, wait a minute here. First of all, you have different testing standards for vaccinated versus unvaccinated, which can predictably give you certain outcomes. It's going to skew data. I mean,
it's going to make it look like an outbreak of the unvaccinated. That's what they wanted, and that's what they got.
Well, didn't we see recently that that they published what percentage of new infections were unvaccinated, but they took the sample before people were vaccinated. So almost everybody was unvaccinated, and they lie with the data.
You've got it, 100%. So this is the public health paradigm in the United States. Now, Israel, they were more honest. They said, look, these are breakthrough cases, and most of the cases are breakthrough. The UK, they were more honest. For some reason in Barnstable County, we got an actual read on what was going in, right? So we know that there's more vaccinated breakthroughs percentage-wise than there are unvaccinated. In Barnstable County, I looked at the data and I did the calculations. If you had one vaccine, the vaccine efficacy calculations are 0. It's a big goose egg. The vaccine is ineffective. You might as well have not got it as equally as well as you might have gotten it. You're still going to have a breakthrough. You're still going to have an infection. But if you got 2 doses, you're more likely to have an infection.
Whoa.
Negative efficacy means you're more likely. The vaccine is causing antibody-dependent enhancement. It's causing the disease, right? So this is what the Barnstable, now it's arguable that, wait a minute, there's a bias, it's observational data, but I didn't create that situation. They did. They created that situation when they vaccinated all the control groups and all the clinical trials. If they didn't vaccinate all the control groups, we'd have the long-term data. They should have let them run on and on and on as long-term data.
What do you mean they vaccinated the control groups? You mean after the study, they decided to vaccinate all the controls also?
After the short-term study, because it was unethical not to vaccinate them because they might get some protection.
Well, how would they know? They didn't run the study completely.
They destroyed the studies. Yes,
Yeah,
they
they destroyed
destroyed
the studies.
science, and this is what they do. Thankfully, we have the data from Israel, from the UK, that shows exactly what's going on. And you know what's happening in the UK? They're turning towards treatment. They're turning towards the list of treatments that you just talked about. Ivermectin, hydroxychloroquine, they're taking a good, serious look at it. Fluvoxamine, they're looking at all of it. Now, they are going to survive this better and sooner than the United States. We're going to go through a whole bunch of social gyrations of masks versus unmasked and vaccinated versus unvaccinated. People are being manipulated. They're becoming programmed by the state now. The new message from the state to get out on social media is ivermectin is for livestock. Why are these anti-vaxxers using medicine for livestock? They know nothing about the massive amount of science of its use in human medicine. It used to be called a wonder drug for human medicine because it did so many things. It's from a plant. It's a derivative of a molecule from a plant. So if you're into natural things, there you go. But the point is, we have no leadership capable in the United States. It's not. I'm not making this political. We have no real leadership in the United States. There's a leadership vacuum that no one has the willpower, the spine to stand up to the CDC.
But you are, and other people are standing up. I mean, you're standing up to them, and I think there's a growing chorus. The Great Barrington Group, I mean, there's a lot. I think it's a growing chorus standing up because it's just getting to the point of being outrageous. But let me ask this question: what is the risk anyway? What I love about you is you're a great data nerd. I mean, you really understand your statistics and know how to run them. And and I hear different numbers, but what is the mortality rate on COVID?
Because they changed the CT threshold for the vaccinated, we don't know the hospitalization rate. We don't know the infection rate. We don't know the death rate in the vaccinated compared to the unvaccinated. We don't know the reinfection rate. At this point in time, when the director of the CDC announced that they were going to change the CT threshold for the vaccinated, no report can be considered credible unless they show the distribution of the CT thresholds. For some reason, that Barnstable County showed their CT threshold, and it was the same. They had the PCR results on the samples, and it was the same. So that one's valid. And it means that the vaccine efficacy is 0 or worse, right? But they don't have survivorship on that. They don't have mortality.
Putting vaccine efficacy aside, and safety aside, which are very questionable things, the question is, in general, COVID-19 as a disease, when it becomes symptomatic, I'm hearing the mortality is 0.2%. And now we can go into subgroups, obviously, and younger people, older people, et cetera. But, it seems like there's a bunch of drive and rhetoric that this is like a deadly disease, which is why we are going through these extraordinary measures and vaccine will prevent it, which is why we have to censor anybody who would create vaccine hesitancy amongst people who know how to think. Interestingly, though, the biggest vaccine hesitant population are PhDs, people who have the most education. So they're not prone to people's opinions, they're prone to doing their own reading and research. But do you have any numbers that you have arrived at relative to what the mortality is of COVID? Should somebody who's unvaccinated, let's not compare vaccinated to unvaccinated from it. Let's just say that there was no vaccine. What's my risk?
Okay, so the most responsible thing that I can say to you is it depends on how aggressively you pursue early treatment.
Mm-hmm. Okay.
Your risk of mortality is directly proportional to whether or not you have a doctor that's going to give you a script for something, or whether you're aware of the protocols, or whether you're aware of the supplements that can actually help you get through this in a very good manner. The number one predictor that I know of a serious COVID-19 infection in people who are not vaccinated, this is before the vaccine, is whether you have autoimmunity. So if you already have lupus, if you already have other autoimmune conditions, then you want to do everything that you can possibly do to get the peak shape, peak fitness, clean up your diet, make sure you have sufficient vitamin D around, vitamin A, vitamin C, and all the rest that we all know about, supplementing with zinc and quercetin and everything else prophylactically. and have a handy supply of hydroxychloroquine around, which now I understand you can order from Canada. You can also find a doctor that will prescribe it for you. And when I was saying that there's no leadership, I was saying that there's a change now because ivermectin's prescriptions are soaring. That's the official data. That means allopathic medicines, naturopathic doctors, and so on, osteopaths, everybody's saying, forget it. I'll write you a script. Just forget. Devil may care whether they come from me or not. I'm going to give you a script. Now they'd like to remain anonymous, but their name's on the script. So the point is, we're seeing a stand up movement, and I see signs of a walk away movement where the nurses will not vaccinate and they're taking off from allopathy. And my message to them is it takes about probably less than $500 to create an LLC, and you don't have to be an MD to create a medical facility. You can create a naturopathic facility as a former nurse or a gaggle of former nurses, whatever, and you can start hiring these MDs that are going to lose their jobs because they won't vaccinate. And you can create a viable, vibrant healthcare industry in the United States that is going to be far superior. Now, what do you have going for you? Well, what you have going for you is you don't have brick and mortar, and telemedicine is legal. So if you can compete against standard allopathy through telemedicine, you're going to get a leg up on the market big time because your costs are so low.